Okay, so cortical sensation is composed of 5 different things. The first thing it's going to start with is it's called stereognosis. Okay, so you're going to have the patient close their eyes. And you're going to go ahead and put your hand out. I'm going to put something in your hand. I want you to just identify it for me without looking at it. Okay, one hand at a time. Don't put it between your 2 hands. Good. And then you could use a pen, basically a simple object that the patient would be able to recognize by touching. Okay. The next aspect we're going to talk about with cortical sensation is 2-point distinction or discrimination. So what you want to do is you want to either have like one of those things I was using before, something sharp, but basically a common paperclip just bent like this will work just fine. So what you're going to do at 4 different locations, 4 to 5 different locations on each appendage, you're going to go ahead and take, starting wide and working in. So you go ahead and have the patient close their eyes. And you just tell me if you feel one or 2 points of contact, okay?
2.
Okay.
2. 1.
1, right? No. Okay.
2.
Okay. And each time you do it, you just want to bring it in a little bit more, okay?
2. 2.
Okay, so what you would do is, once you find where the patient says it feels like 1, but there's actually 2, you would measure that distance and record that as the 2-point distinction, or 2-point distinction measurement. And it can range anywhere from 2 millimeters to 75 millimeters, depending on what dermatome you're in. So the next one we're going to do is going to be 2-point or point extinction. So what you would do is you have two sharp areas, but instead of doing it right next to each other, what you're going to do is have the patient close their eyes, and you go ahead and you just ask them, you just tell me how many points I'm touching you with, okay? And instead of it being right next to each other, it's going to be wider apart. Extinction phenomenon, sorry. So it's going to be like this.
2.
Good?
1.
Okay.
2.
Good?
1.
Okay. And you would do that, obviously, bilaterally. And what you're looking for is to make sure that the patient feels things on both sides of their body equally if there's 2 different sensations. Okay? The next part is graphesthesia, and that is accomplished by taking the patient's palm, and you're just going to have them close their eyes. And what I'm going to do is I'm going to write a simple letter or number, and I'm just going to want you to identify that letter or number, okay? So without looking. So we'll do
8.
Good. And then you do it again with this side, and it'll be a number.
2.
Good. So good for graphesthesia. And the last one is going to be point location. So similar to extinction phenomenon, I'm going to take and I'm going to basically apply, I'm going to produce sensation somewhere on the patient's body, but then I'm going to remove the sensation and I'm going to have them identify where it was. So, good. And they should be able to locate in the general area where you touch them without you actually touching them, continuing to touch them. Good. And you can do that again bilaterally, distal, proximal, legs, and arms. Okay? Now, the second part, or the next part, is going to be reflexes. Now, there's 2 areas of reflex. There's superficial and then deep tendon reflex. So, superficial reflex, you can actually have the patient lie back. Go ahead and lie down. Make sure you pull up, make them comfortable. And you're going to do, you can leave your shirt down. I'm just going to visualize it. So, what you would do is, with your reflex hammer, this type of reflex hammer works better because it's got kind of a sharper point to it, but you could use these too. But what you're doing is you're eliciting the abdominal reflex, and what you're doing is you're going up and away, and you're looking for the umbilical area, and it kind of contracts a little bit. That's your positive reflex, okay? So that would be abdominal, and that's for men and women. Now, when you get down with men, there's the cremastric reflex. So what you're going to do is you're going to take on the inside of the thigh, you're going to go proximal to distal in a downward motion, and the patient's scrotum will actually rise from that reflex. So that's a reflex. And the last one is going to be, and this for, obviously you're not going to do that one for females, but for guys, that's what you're going to do. The last one is the Babinski's. So you're going to go from the lateral side of the foot, and you're going to take the tail of your reflex hammer here, and you're going to go up in a curving motion toward the big toe. Okay, you see that? So it's going to be like this, and what you're looking for is the toes to actually flex in. An opposite reaction, that is if they sprawl out, that's not a good sign, let's just put it that way, okay? So those are your superficial reflexes. Now your deep tendon reflexes, there's 5 of them, all right? So you're going to start with the arms. Easiest way to do this is, I come up behind the patient here, so my left arm, his right arm. I'm going to go ahead and have him relax his arm, okay? And you start with your bicep tendon, okay? So all you're going to do is you're going to come in here, go ahead and relax your arm. You can have him look away or whatever you want to do, but your bicep tendon is right in the antecubital space here. You're going to go ahead and elicit a reaction out of it there. Next is you're going to go ahead and do the brachioradial deep tendon, and that's right in this area, and you're just looking for that reflex, and you can kind of feel it tense up, and you'll sometimes see the hand move. And then the last one here on the arm is the triceps tendon, which is going to be in this area. Sometimes it might take a couple strikes to actually find it, but you just have the patient relax, make sure that their arm is relaxed, and yeah, and that's basically the type of reaction you'll get. You'll get a nice kick out of the arm. Now the other two, you're going to do, and you would do that bilaterally. You could check right and left side. Okay. The next one you're going to do patellar, so that's the most common one everyone always sees, and then bilaterally with that, and then your Achilles tendon, okay, is all you have to do is elicit a strike to the Achilles tendon, and you're going to get a flex out of the foot down, okay? And then the last thing you're going to do with reflexes is a test called ankle clonus, okay? So I'm going to come down here, okay, so I'm going to basically flex, dorsiflex and plantar flex the foot back and forth several times to kind of throw the patient off, and then I'm going to hold it up. And ankle clonus, a positive ankle clonus would be if you have that bouncing sensation when the foot is flexed back like this, okay? So go ahead and show it one more time. That would be a positive ankle clonus, all right? The last section, while you're down there, you could do it, would be protective sensation, which you would do with diabetes patients, and that would involve taking monofilament and touching different parts of the plantar surface of the foot and trying to elicit a sensation from a diabetic patient. With diabetes, they end up losing sensation sometimes down in the distal parts of their appendages. So the last 2 tests that we're actually going to perform, obviously you're going to verbalize that during the PCL, but the last PCL we're going to actually, or the last test we're actually going to perform is called Kernig's, called Kernig's and Babinski's, okay? Or Brzezinski's. Brzezinski's, sorry. Yeah. So Brzezinski's is going to be where you're going to have the patient go ahead and touch their chin to their chest, and go ahead and have them cross their arms across their body, just like this. Go ahead and touch your chin to your chest for me. And this shouldn't elicit any pain. It shouldn't elicit any flexion of the hips. This is all meningeal signs. Go ahead and you can relax. So a positive would be as if the patient couldn't, even with assistance, flex their chin to their chest without some sort of pain being elicited in their spine or their neck. Okay? And the next one is called the Kernig's. Okay? So you're going to basically assist the patient and flex the leg up like this. Okay? And you keep it at a 90 degree, and then you're going to go ahead and flex the ankle and foot up to 90 degrees, and you're just looking for the same reaction, that pain, or that flexion of the hip. Basically the same as the straight leg raise. All right, you can lower your leg. But you're looking for more for meningeal type signs, okay? And that's the entire PCL, head to toe. So any questions? Go ahead and run them by me tomorrow before the PCL, but you should be fine.